talk about, maybe Andrea can start us off, is what defines a relapse, and at which point that should we consider the treating the patients again?
Sure. So various papers have looked at the rates of relapse. It's usually between 30 to 50%, depending on what you're looking at. And technically, true relapse, so not someone who has disease that still, had a PR to initial therapy, but at an initial, at least clinical CR by counts and things. A true relapse does not need to be retreated again until they meet the criteria for treatment as if it were a de novo, they're a treatment-naive hairy cell leukemia. So again, basically pancytopenias or other symptoms. And that's because, again, while absolutely treatable, it's not curable in the long run. So you don't need, if the patient's doing well, has some mild cytopenias, and you detect that it is present, treating them doesn't necessarily change their course, and you're exposing them to treatment that they may not need and all those side effects. Additionally, we do know, and this is partly where the MRD debate comes in, that with each subsequent treatment, at least, with the purine analogs, your remissions are likely to get shorter in between. And so exposing patients to treatments when they don't need them may end up using up treatments faster. So for all of those reasons, we do not need to treat them until they're showing symptoms again that would require treatment as outlined before. And then one thing that's really important is the timing. So it's really that what's come out is that if you relapse with less than 2 years versus relapsing after 2 years. And part of that is basically because if you're relapsing you've had a longer response to a purine analog, you may respond, and often do respond, with, again, long period of duration. So if someone had fludarabine 10 years ago and relapses again, then you certainly could get another long duration with rechallenging. Versus a patient who is relapsing less than 2 years, the likelihood of them having a durable response when they didn't initially is much shorter. And so those are important keys to think about when you're picking what to do next and when to treat.
And I may actually ask Dr. Coutre, if that's okay, maybe some of the, what are the options actually for the second line or third line therapy for relapsed refractory hairy cell leukemia? Some of the guidelines, I know there's NCCN has listed some of the drugs, and Dr. Sitlinger also mentioned that to retrial the cladribine again or the pentostatin, and those, especially those late relapse patients. But how is the landscape has changed and over the course of the last several years with this research that's been done in this area?
Well, I would say, following with Andrea's comments, that somebody who's had a long durable response, I would retreat with cladribine or cladribine with rituximab. I would not advocate changing purine nucleoside analogs. I really don't see the point of that for a patient like that. And then, of course, there's our clinical trial options that we've touched on. Ibrutinib is in trials, the BRAF inhibitor mentioned, and other BRAF inhibitors are in trials. And so those can be perfectly appropriate options for patients too. We're always trying to develop new and more effective therapies. And then we do have an approved drug, but I believe that's for second relapse, not first relapse patients. So like many very uncommon hematologic diseases, we have a wealth of options, which is always nice.
And Dr. Sabin, perhaps, let's say if the patients receive the cladribine or pentostatin as a first-line therapy and they relapse, when you retreat them with again, cladribine, for example, would you add rituximab at the second time that you did it? You do it if they didn't receive the first time?
Generally, I add the combination to patients when they've relapsed, unless there's some reason why I wouldn't add the rituximab. But generally, I do combination therapy for patients who relapsed. The person's first remission is 12 years. I think it could be debated, but if the patient's remission is 3 or 4 years, they didn't do as well as they're supposed to do, and then I'd be inclined to add the rituximab. Andrea does quote that 2-year interval, which I always found a little humorous, because I was once asked to write a review and I sort of came up with a number 2. And then I know it came into all consensus, and then came into the NCCN guidelines, but I'm not sure 2.5 is less than 1.8 years. I think it's, if the patient doesn't do like everybody else and has a brief remission, whether it's 2 years or 2.5 years, he's sort of told that he's not that sensitive to purine nucleoside analogs. So I don't think the 2 years is on the 10 commandments. I think you can use your clinical judgment as to the advisability of reintroducing the purine nucleoside analog. It was also thought that pentostatin and cladribine were almost exactly the same drugs, but they aren't. And when I was a fellow, I wrote a paper in Annals of Internal Medicine. It was 5 patients who were refractory to pentostatin. They had got a number of times and were clearly refractory. And then we introduced cladribine. They actually responded. And then the papers from Dearden in the UK, in which she gave, which patients got cladribine first and later got pentostatin and then responded. So the mechanistic dissimilarities between the purine nucleoside analogs, and they're not exactly the same drug, although they're very similar. What concerns is the repeated use of a purine nucleoside analog can damage the bone marrow in and of itself. So subsequently, you may clear the hairy cell, but you may induce hypoplastic changes in the bone marrow. Also, there's the cumulative effects of profound immunosuppression. So they're not the same drugs, but they have similar long-term consequences.